Hello and welcome to your first video on our Chapter 38 video lecture series where we're talking about alterations of digestive function. We'll start off with anorexia, and this is when there's a lack of a desire to eat despite physiologic stimuli that would normally produce you to become hungry, and it's associated with nausea, abdominal pain, diarrhea, psychological stress, and weight loss. Next up, we have vomiting, and this is the forceful emptying of the stomach and the intestinal contents through the mouth. And if you remember, that vomiting center is in the medulla oblongata. So we have some type of stimuli. We have many different types, but this could include things like severe pain, distension of the stomach or the duodenum, or if you're one of those people that get motion sickness, it could be your vestibular system through cranial nerve number 8 that is stimulated, or it could be a drug's side effect that initiates that vomiting reflex in the medulla. And initially what is going to happen is you have this deep inspiration, your glottis in your larynx is going to close, and your abdominal muscles start to contract, while that lower esophageal sphincter and your stomach muscles relax, and that pressure builds up to push the contents through reverse peristalsis, as well as just that pressure pushing everything up in order to cause the vomiting. And so some of the symptoms are going to be hypersalivation and tachycardia. Although prior to vomiting, you may have some symptoms of nausea, which is more of a subjective experience that's going to be associated with a number of different conditions. And there's also retching, known as dry heaves, in which it's more of a muscular event when we are having non-productive vomiting. So these muscular contractions that simulate vomiting, but nothing is coming out. Whereas projectile vomiting, we are definitely having substances moving out. This is a spontaneous type of vomiting that is not going to follow nausea or retching. That is because we have direct stimulation to that vomiting center in the medulla by some type of neurological lesion. So it could be due to maybe an increase in intracranial pressure, a tumor being present, or an aneurysm within the blood vessels there. Or it could also be stimulated through pyloric stenosis, which we're going to talk about later on in this chapter. And then just a little note on the side here that with vomiting, we may develop hyponatremia, hypokalemia, hypocaloremia, and metabolic alkalosis. Our next manifestation is constipation, and this is defined as infrequent or difficult defecation. We see that it primarily affects people that are over 65 years old, and there's two different conditions, the primary condition and secondary condition. So we'll start off with the primary, and this could be classified into three categories. First is normal transit, or a functional condition in which they just have difficulty evacuating. And this is associated with people that have a sedentary lifestyle. Maybe they're not taking in enough fluids, or they're eating highly refined foods. The second category is slow transit, and this is when we have impaired colic motility, meaning we're not really able to move the contents along the way we should be. And then there's pelvic floor or outlet dysfunction, in which we cannot relax or coordinate those pelvic floor muscles in order to evacuate the feces. Now, once we get into the secondary conditions, we'll see that these are due to different factors such as diet, medications, some disorders, or aging processes taking place. As far as some of the disorders that could cause constipation, it could be patients that have suffered from a stroke, have Parkinson's disease, spinal cord lesions, multiple sclerosis, or Hirschsprung disease. Essentially, it's going to be anything that is affecting those neural pathways or neurotransmitters that may delay the transit time. With aging as the cause, it could be because we have decreased mobility, and that causes the neuromuscular function. And they may also be using multiple medications and have comorbid medical conditions that can all cause the constipation. And we also just have to note here that if we have a change in the bowel habits, it could be indicative of colorectal cancer. So you always kind of have to have that in the back of your head. All right, now let's talk about some of the clinical manifestations. So you can classify as someone having constipation if it includes two of these for 3 months. And that is going to be straining with defecation at least 25% of the time. And with that straining, it could cause engorgement of the veins within that area and cause hemorrhoids to take place. Or there would be thrombosis with rectal pain, bleeding, and itching. Hard stools at least 25% of the time, and this can cause painful anal fissures to develop. Sensation of incomplete emptying at least 25% of the time. Manual maneuvers to facilitate that stool evacuation at least 25% of the time, or if you have fewer than 3 bowel movements per week. So something that patients can do is keep a diary of their constipation if they're taking certain medications or maybe certain foods that are causing these episodes to take place. And also they can include if they are using laxatives or enemas in order to be able to evacuate their feces. To help with diagnosing this, there could be a digital examination to assess the sphincter's tone and detect any lesions present. Colonoscopy can visualize the lumen, and as far as treatment, it could be just figuring out what is the disease or underlying process that is causing the constipation to take place. You can recommend that the patient exercises more, drinks more fluids, and takes in fiber through the foods they eat or taking a fiber supplement. Maybe they turn to taking stool softeners or laxative agents, and enemas can also be useful to establish a bowel routine, but we don't want this to be habitual. And as a last resort, when we are not able to respond to any dietary or medical therapies, a colectomy is done where they remove part of the colon or the entire colon, and they can attach the ileum to the anal region. Now let's switch to the opposite issue here, which is diarrhea. And this is when we have a presence of loose, watery stools, and we can classify them as being acute, persistent, or chronic. So acute means that we have 3 or more loose stools in 24 hours, and this lasts less than 14 days, which is the case for a majority of the population. But if it is going to last longer than 14 days, that is persistent. And if we go over 4 weeks or a month, then it is classified as chronic. Now we can classify diarrhea as also being large volume and small volume. Large volume means that we have a increased volume of feces, and this could be caused by excessive amounts of water or secretions or both in the intestines, whereas small volume diarrhea is because we have a decreased volume of feces, and this could be due to some type of inflammatory disorder of the intestines, including ulcerative colitis, Crohn's disease, or microscopic colitis. It can even be indicative of colon cancer or fecal impaction. And with these, it's usually going to result from excessive intestinal motility taking place. Now let's discuss the major mechanisms here. First, we have osmotic diarrhea, and this is going to be when we have non-absorbable substances that draw that excess water into the intestines and increases the stool weight and volume. And so this in turn is going to cause large volume diarrhea. Our secretory diarrhea is when we start to produce excessive mucosal secretion of fluid and electrolytes. And this too is then going to produce large volume diarrhea, and it's typically due to some type of infectious disease. So maybe it's a virus like rotavirus or a bacterial infection in which we have enterotoxins coming from something like E. coli that is going to cause diarrhea that is going to last less than 2 weeks, or that bacterial organism can secrete exotoxins. So let's say you have a C. diff type of infection that would be secreting exotoxins that are going to cause the excessive mucosal secretions. The last type is motility diarrhea, and this is excessive motility that works to decrease the transient time for fluid absorption to take place in the colon. So this could be caused by something known as short bowel syndrome, where we resection the small intestines, or if we had surgery to bypass the intestines, somebody that also has IBS or diabetic neuropathy, hypothyroidism, or has abused laxatives will limit the time in which we are able to absorb the fluids. Therefore, the fluids get left in the intestines and causes diarrhea to take place. Now, if this diarrhea lasts, we can see systemic effects, and that's going to include dehydration, electrolyte imbalance, namely hyponatremia and hypokalemia, and weight loss. And we see this frequently with malabsorption syndromes that are going to manifest things like steatorrhea, which is fat in the stool, and bloating. So to diagnose someone, we want to have some stool studies done, abdominal imaging, endoscopy, and intestinal biopsies. And to treat this, first is going to be fluid restoration, especially if we see dehydration taking place, anti-motility or water absorbent medications. And of course, if we know what's causing that diarrhea, we want to treat those causal factors. We can also give probiotics for someone that is having a C. diff infection. And if some of the conventional therapies don't work here, there's also the option of fecal transplantation. Moving into abdominal pain. So we can have pain take place through a couple different mechanisms. First one is due to mechanical pain, and this is due to a rapid stretching and distension of our abdominal organs. They're typically not going to be very sensitive to mechanical stimuli such as cutting, tearing, or crushing. But like we said, if we have rapid stretching or distension of that organ, it starts to activate the nerve endings there, and that's when we have pain elicited. And this pain tends to be sharp, dull, or colicky. Next up, we have inflammatory, and this is when we have chemicals that stimulate our nerve endings. And these chemicals can include histamine, bradykinin, and serotonin, and they start to stimulate the organic nerve endings that we have within our organs and produce pain. We could also get the development of edema and vascular congestion from the chemical release, especially if there's some type of bacterial or viral infection that's causing inflammation that then will cause painful stretching and then can link to our mechanical mechanism. Next, we have ischemic, and this is when we just don't get enough blood flow to the abdominal organ and pain develops. So there might be some type of obstruction of that blood flow to the organ that can then result in pain. Next, we have parietal or somatic pain, and this tends to come from the parietal peritoneum. Remember, that's the lining of the abdomen, and is essentially letting us know that this pain is coming from the organ itself. So it's a localized, intense pain. We can also have visceral pain. This comes from a stimulus that acts on an organ. So the stimulus might be a distension of that organ, or inflammation, or ischemia. Basically, the three mechanisms that we have here that could be due to inflammatory mediators, and this type of pain is poorly localized, diffuse, or vague. Lastly, we have referred pain. We've talked about this before, and this is visceral pain that we feel at a distance from the affected organ. So it's well localized, and we also feel that pain in our skin dermatomes or shared afferent pathways. So for example, we have the gallbladder. We're going to feel that where it is located. And just as a reminder, we have this division of the abdomen, right? And so in our right hypochondriac region is where we are going to have that gallbladder pain. But then through those afferent pathways, we also feel it in the right shoulder. Lastly, in this video, we're going to talk about GI bleeding. It could either be upper or lower GI bleeding. So upper GI bleeding includes the esophagus, stomach, and duodenum. And we tend to see that this is going to be associated with varicose veins around these organs that can become damaged and bleed. And this bleeding can be rapid enough to produce hematochezia, but we can also produce melena. And we're going to talk more about these two terms on the next slide. When it's a lower GI bleed, it's going to come from the jejunum, ileum, colon, or the rectum, and it could be due to polyps, diverticulitis, an inflammatory disease, cancer, or hemorrhoids. We're going to touch on all of those in the coming slides in this chapter. And then there is occult bleeding from slow chronic blood loss that is not obvious, and we start to lose some of the iron from our stores within the bone marrow, and that could result in iron deficiency anemia. And we could detect this on a positive fecal occult blood test, which you'll see on the next slide. And if we have acute severe bleeding taking place, this is life-threatening, and it's going to depend on the rate and the amount of blood loss that is taking place. Now, if you look at this figure, it kind of walks you through the process of that acute GI bleeding taking place. And we could see if it's due to upper or lower regions. And all in all, it's going to cause our blood volume to decrease. So that then causes a decrease in our cardiac output. And we've got compensatory constriction of peripheral arteries and arterioles. So what they're going to do is send the blood to our vital organs like the brain. But if all that eventually fails, then we are going to see that we lose blood flow to our brain and the heart, causing these symptoms to take place for loss of blood to the brain, anxiety, confusion, stupor, and coma. For loss of blood to the heart, we have angina, myocardial infarction, pulmonary edema, heart failure, and dysrhythmias. Now, let's also not forget that because we are losing blood, we can develop metabolic acidosis. And so we start to get an accumulation of blood in the GI tract, and it becomes irritating and also increases peristalsis, causing things like vomiting or diarrhea or both. And we can also develop bowel infarction and liver necrosis. Let's also touch on the types of acute bleeding. First, we have hematemesis, and this is when we develop a dangerous condition in which the person is bleeding internally and vomits as a result. So this person is going to need immediate attention, and it could either be a bright red color or it could be this dark grainy digested blood that almost looks like coffee grounds. Then we have melena, in which it's a black, sticky, tarry, and foul-smelling stool. And basically we have a digestion of the blood that takes place, and it looks like this over here. We can also see this type of stool if someone is taking dietary iron supplements, eating a lot of blackberries, or has taken bismuth, also known as Pepto-Bismol. Third, we have our hematochezia, and this is when we have a bright red type of blood that has been passed from the rectum. Like we said, we can have this take place in an upper GI bleed that is very rapid, but generally we have some digestion of that blood, and that is going to develop into melena. And lastly, we have our occult bleeding, in which we have some blood in a normal appearing stool. So we can't really just tell that there's bleeding taking place by looking at the stool sample, but we can perform a fecal occult blood test in order to see if there's any blood present within the stool.